Good morning, everybody. Welcome to this webinar this morning. I'm Hazel Cheeseman. I'm Director of Policy at ASH, and I'm really delighted to be doing this webinar on behavioural support and stop smoking services. It's a really interesting moment. You know, we've had a year now of delivering our services remotely in pretty unprecedented and challenging circumstances. And what we have found throughout the pandemic is that people have been incredibly innovative in stop smoking services up and down the country. And there's been so much innovation during this period that it's this is, I think, the start of a bit of a stock taking as to what has been done over the last 12 months. What's the impact of that been? What's been successful? What hasn't? And to think about how we learn from the last 12 months and what we might want to take forward as we hopefully move on from the pandemic at some point in the future. And I think this webinar will hopefully be the start of that conversation. I don't think we're going to be able to answer all the questions today around how we might serve different populations, how we're going to manage our the ever increasing pressure on our budgets, how we retain quality services in changing methods. But hopefully this webinar will be a bit of a space to kind of revisit what we've done over the last 12 months, what the evidence base is, and how we might answer some of those questions going forward. So I'm really delighted that we're joined by Dr. Jamie Hartmann Boyce, who's going to talk about bring us back to the evidence and talk about the findings from the most recent Cochrane review. And Jamie's going to kick us off shortly. And then we'll hear from Robbie from ASH, who'll be talking about the results of our annual survey of stop smoking services of local government, and giving a sense of what the picture has looked like out there over the last 12 months. And then we'll be joined by colleagues from NCSCT, by Louise and Sophia, who are going to help us to start think about some of the questions about how we might retain quality going forward. And then really delighted that we've got 3 really interesting case studies about how people have been delivering in the pandemic from Essex, from Yorkshire, and from Bath and North East Somerset. And I would say that we've had loads of great case study input in our webinars throughout the last 12 months. And looking back, if you want to look back at any of those, I'm sure there's still lots that can be learned from them if you haven't seen them already. Right, so that's enough waffling from me. Move on to the next slide, Robbie, and remind people how they ask questions. So you'll see there's a question tab in the sidebar. If you want to ask questions, please do. We're going to have lots of time for questions at the end, I hope. And if you pop your questions in the sidebar there, we will get to as many of them as we can at the end. But if you've been on an ASH webinar before, you'll know if we don't manage to answer your questions on the day, we do always try to come back and answer them in writing. So should we move on, Robbie? And I will hand over to Jamie, who's going to lead us off with a discussion about the evidence. Thanks, Jamie.
Hi, everyone. I'm just going to bring up my slides. So I'm trusting everyone can see these, and if they can't, they will let me know. But assuming you can, hi, everyone. Thanks so much for listening to me today. My name is Jamie Hartmann Boyce, and I work with the Cochrane Tobacco Addiction Group at the University of Oxford. And today I'm going to be talking about the latest findings from a suite of Cochrane reviews relating to behavioural support for smoking cessation. This project, so what I'm presenting today, was funded by the National Institute for Health Research, which is the research wing of the NHS. And I don't have any conflicts of interest to declare, but I do just want to declare, I suppose, so much thanks and gratitude to all the people who helped on this work, which includes my wonderful colleagues at the Cochrane Tobacco Addiction Group, shown on screen, and also loads of other authors who contributed their time. So for anyone who's not familiar with Cochrane, we're a global nonprofit that exists really to help people make healthcare decisions. So we do this by gathering and combining evidence in something called a systematic review. And what that means is we bring together all of the studies that answer questions about the benefits and risks of a healthcare intervention, and we follow Cochrane methods, which are considered gold standard. So not only are we bringing together these studies to see what they find and what happens when we combine the data, but also to figure out how much we can trust them and what the strengths and weaknesses are in the evidence base. And the reason we do this is to help people making healthcare decisions. With many of these areas, we have hundreds of trials, tons of evidence, way more than anyone can get through when they're taking into account lots of things. So what we hope to do is provide a transparent, rigorous, and unbiased account of the evidence so that anyone making healthcare decisions can have that to hand. And that includes lots and lots of guideline developers, policymakers, and service providers, particularly with the work from the tobacco addiction group. So as I mentioned, part of Cochrane is bringing together the evidence, and the other part is saying how certain we are in it. And throughout this talk, when I cover different areas of behavioral support, I'm going to be talking about the certainty we have in the evidence. So I just wanted to quickly explain what I mean by that. In all Cochrane reviews, we use a framework called GRADE to determine how certain we are in the evidence in front of us and in the effects that we've found. And these grades can range from high certainty, where we're really quite confident that the true effect lies very close to our estimate, and we don't think that any new research is going to change our estimate. And that ranges all the way down to very low certainty, where we are not at all confident in what we found. We think the true effect might be radically different from the effect that we present, and we think new studies might really change our results. And so what I'm going to focus on today are high and moderate certainty findings, because we would not suggest that people make decisions if they can avoid it based on low or very low. Yeah. So what we did for the past few years was we went through and we updated a lot of our Cochrane reviews, which looked at different types of behavioral support for smoking cessation. So we updated 16 individual Cochrane reviews, and we did this to feed into what this project culminated in, which was an overview of reviews and network meta-analysis. And I'll come on to explain those terms in a little bit more detail as we go through the presentation. But what the first bit means is we gathered evidence from lots of different Cochrane reviews in this area. And what the second bit means is that we brought the studies together from those reviews and looked at how they compared to one another. And in the second component, what we were really interested in wasn't whether behavioral support as a whole can help people quit smoking. Of course, we know it does. But how we optimize that behavioral support. What are the different components that contribute to behavioral support for smoking cessation, and how do they compare to one another? So for our overview, we followed standard Cochrane methods, and we looked at Cochrane reviews of behavioral interventions. And our definition here was really broad. So by behavioral, we basically meant any non-pharmacological interventions. And we ran our searches in 2020 and included quite a few reviews, 16 of which we updated as part of this project. We then went on to conduct a network meta-analysis. So we used the reviews we'd found to identify randomized controlled trials, which are typically considered the best way to test whether or not an intervention works. And I won't go into the details of the statistics behind this, but we used something called component network meta-analysis. And importantly for this talk, we looked at 38 different components of behavioral intervention. So those included things about what was actually delivered in terms of the content of that intervention, how it was delivered in terms of the delivery mode, and who delivered it. And we used GRADE to evaluate the certainty of the evidence for each of these different elements. Now, quickly to just tell you a bit about network meta-analysis. In a typical Cochrane review, what we're doing is we're comparing two things. So let's say we have intervention A, and we're interested in how it compares to intervention B. And what we do is we bring together all of the studies that compare A and B and come up with our best estimate of the realistic effect when you compare the two of them. But let's say a new intervention comes on the scene, intervention C, and we're interested in how intervention C compares to intervention B, but we don't have very many studies showing that. What we do in network meta-analysis is we use the studies that compare intervention A with intervention C and the studies that compare intervention A with intervention B to infer how B and C might compare to one another. So network meta-analysis is really about bringing together all of the evidence we have in an area in order to make the most sense about how different things might compare to one another. So first of all, the one group of components that we looked at in our network meta-analysis were the intervention focus and the nature. And by the focus, we mean, was the intervention focused on how to quit? Was it focused on why to quit? Or was it really equally focused on both? And by the nature, we mean, did it include elements relating to motivation, so helping people get motivated to quit? Did it include information about adjuvant activities, which most commonly would be about medication? And did it include self-regulation components? And what we found was moderate certainty evidence that interventions which included how to quit components were more likely to lead to greater success in quit rates at 6 months or longer. So each of these estimates isn't about an intervention as a whole, but about the contribution of that individual component. So there is definitely evidence there suggesting that focusing on how to quit led to greater success, but also, just to point out, moderate certainty evidence that including information on motivation to help people be motivated to quit also helps. So we're not saying this evidence shows that we shouldn't be talking about motivation, but just that focusing overall on how to quit seems to be associated with greater success. When we looked at behavioral content, we found high certainty evidence that behavioral counseling increases quit rates, and also that guaranteed financial incentives increase quit rates. And what we mean by that are incentives for remaining abstinence that are guaranteed. And we compare those to incentives that are not guaranteed, which might be competition. So, okay, if you're abstinent, then you get entered into a prize draw. We didn't find evidence to suggest benefit of those, but we found really clear evidence from these guaranteed financial incentives. And I'll go on a little bit further to talk more about guaranteed financial incentives and counseling a bit further on in this presentation. We also found moderate certainty evidence that tailoring interventions to the individual receiving them increased quit rates. And this is obviously any kind of face-to-face individual intervention delivered by a person will be tailored, but this was also across things like print-based interventions, web-based interventions, tailoring to the individual. We found moderate certainty evidence that that also increased success. So when we looked at delivery mode, very low and low certainty evidence for all of the different delivery modes we looked at. That doesn't mean that, for example, if we look at face-to-face counseling, there's no evidence that face-to-face counseling works. What we mean is that there's no evidence that delivering it face-to-face versus delivering it, for example, by telephone or by an interactive video chat makes a difference to the effectiveness of that counseling. What we did see was moderate certainty evidence that delivery via text message, so SMS on this slide, was associated with greater success, and I will come on to discuss that in a bit more detail as well. We didn't find any moderate or high certainty evidence that any one provider was more beneficial than another one. So moving on to behavioral counseling and just getting into the evidence here a little bit more. The evidence here is really overwhelming in terms of its certainty that behavioral counseling does indeed increase people's chances of quitting. So we had over 190 studies looking at this with over 70,000 participants, which estimated when we combined this data that providing behavioral counseling increases the chances of quitting by 20 to 70%. There was no evidence of harm, and this effect was present whether or not pharmacotherapy was also provided. So in some of these studies, all of the participants were receiving some sort of stop smoking medication. In other studies, no one was. And what we found was that the benefit of behavioral counseling was present regardless of medication, but was slightly more pronounced in people who weren't using medication. Now, moving on to monetary rewards for quitting smoking, or guaranteed financial incentives as we referred to them. In our main review here, we had 30 studies with over 20,000 participants, again showing no evidence of harm, high certainty evidence of benefit, increases chances of quitting by 30 to 70%. And an important point to make here is that in our component network meta-analysis and in our review, where we're looking specifically at financial incentives, we're not just talking about pregnant populations. So in our main review, we split this into populations that were pregnant and kind of a general population of people who smoke. And what I'm showing here is this evidence from the general population of people who smoke, where in reality, we're typically not delivering financial incentives to this group of people, but there's really compelling evidence that it can help people quit. Now, as I mentioned, we did have evidence that regardless of whether or not people were receiving stop smoking medication, behavioral support further increased quit rates. And an analysis just looking at studies where everyone was receiving evidence-based stop smoking medication, we had over 60 studies, over 20,000 participants that showed that adding behavioral support to medication increased chances of quitting from 8 to 22% compared to medication alone. And again, that was high certainty evidence there. So we know from this that really the best chances of quitting smoking are using both evidence-based behavioral support and evidence-based medication concurrently. Now, of course, because of the pandemic and because of resource constraints that will exist even beyond the pandemic, there's a particular interest in remote support. And what our component network meta-analysis didn't find, essentially, was any evidence that there was a difference in the effectiveness of behavioral counseling or financial incentives, depending on whether they were delivered remotely or in person. When we look to the individual reviews of telephone counseling for smoking cessation, we had moderate certainty evidence from almost 90 studies and over 70,000 participants that telephone counseling indeed increases chances of quitting, here by 15 to 60%. And the reason this isn't high certainty is because there was variation in the studies that we couldn't explain. So some of them were finding really clear evidence of benefit and others were finding no difference. And with text messaging based interventions, again, we found moderate certainty evidence of benefit of an increase in quit rates of 20 to 100%. No evidence of harm, but here again, some studies finding a difference, some studies finding no difference. But both of these look promising, and what we didn't find was any compelling evidence that delivery mode was the thing that was driving effectiveness. But we would want to see more studies to test this, and particularly more studies directly comparing these different modes. And finally, another review that we updated as part of this, just to end on, was looking at cutting down to quit. So it had previously kind of been accepted that the best way to advise people to quit smoking was to quit abruptly. But we know that for some people that can be difficult, that can be off-putting. And so what this review was looking at were interventions that were helping people reduce their smoking with the ultimate aim of quitting. So the aim of these interventions was abstinence, but in order to get participants there, they were gradually reducing how much they smoked. And we had over 20 studies, over 9,000 participants, that showed that the approach you take in terms of advising abrupt quitting, stopping all at once versus cutting down to quit, appeared to make no difference, with no evidence of harm from either approach, and we found moderate certainty evidence here. So hopefully that should be somewhat encouraging, that if people aren't quite ready to abruptly quit but are open to reducing and on the road to quitting, that shouldn't make a difference to take that approach. So in conclusion, what this suite of work found was that behavioral support for smoking cessation can increase quit rates at 6 months or longer, and there was no evidence that support increases harms. This was the case whether or not pharmacotherapy was also provided, but the effect was slightly more pronounced in the absence of pharmacotherapy. The evidence of benefit, as I mentioned, was strongest. We had high certainty evidence for any form of counseling and for guaranteed financial incentives, and that was in a general population of people who smoke. The evidence suggested possible benefit, but the need for further research to evaluate tailoring of interventions to the individual, delivery via text message, and intervention content with motivational components, but an overall focus on how to quit. And of course, there are limitations to the evidence. Future studies, we really hope to see them. We hope to incorporate them in future Cochrane reviews. And we hope that they're well described, particularly around socioeconomic factors. That was something we wanted to look into in our review, and we really didn't have enough data to look into in much detail. And there too, we'd like to see more studies in lower income settings. So I'd encourage you to look at the full review if you're keen to see more detail. We also have a commentary in there summarizing the economic evidence we have for the cost effectiveness of behavioral support for smoking cessation. And it's a very long document, incredible amount of detail, but it also has a plain language summary, which is aimed really at anyone, but particularly at people who might be interested in quitting, to explain what the evidence shows. So thank you very much. And I'm happy to take questions at the end of this webinar.
Thanks, Jamie. Fascinating presentation, and you've set a high bar for sticking to your time as well. We're bang on time. Several people are asking if the slides and the will be available. We'll certainly circulate slides afterwards, and the recording will also be available. So if you've other questions, we're going to address them at the end. And if Jamie's fascinating presentation there has provoked some thoughts in you, please do pop your questions in the chat now so you don't forget them later. And we'll come back to them. So we're going to move on now to look at the picture of stop smoking delivery over the last 12 months. I'm going to hand over to Robbie to talk through, from ASH, to talk through the findings from our most recent survey of local authorities. So over to you, Robbie.
Hi everyone. So thank you, Hazel. I'm Robbie Titmarsh. I'm a Senior Policy Officer at Action on Smoking Health. And yeah, as Hazel was saying, I'm just going to take you through kind of the context of the last year, and what we've kind of seen in changes to the delivery of behavioural support, and just kind of try and take in the wider context as well and some of the things we should be considering in light of all this. So just kind of setting up the framing for the rest of the webinar as we kind of focus in on those discussions a bit more. I'm just going to turn off my webcam now to try and not upset the Wi-Fi, but hopefully you'll all still hear me fine. So the things that I'm going to kind of show you, the findings, are largely from our survey of tobacco control leads in England. So this is an annual survey which is commissioned by Cancer Research UK and conducted by ASH. It's a survey that many of you are probably familiar with, and I just kind of like to take this opportunity to say a huge thanks to everyone for continuing to support us with this and completing the survey this year. We had a really good response rate, I think, of 74% of all local authorities with responsibility for public health in England. And that's, yeah, really quite similar to other years, which is fantastic given everything that was going on. So I'll just show you kind of a few key bits relating to today's focus, but I'd really encourage you to go and have a look at the full report. And we've also done a summary presentation, which is kind of specifically looking at the recommendations in the report and very much designed for tobacco control leads and kind of stop smoking service managers. So just to flag that those are there. So I'm going to start with just the kind of context prior to the pandemic. So this is a table showing the delivery of stop smoking support, or the stop smoking support rather, that was commissioned and planned for 2020 and 2021. And as I say, it's just keeping it brief here, that the most notable point prior to the pandemic was a kind of shift towards a universal, shift towards a specialist stop smoking service, that is. So we saw about 77% of local authorities surveyed planning to commission a specialist stop smoking service, which was up from 69% in 2019 and 65% in 2018. The vast majority of services were going to be universal or had some form of universal offer via other means, such as telephone support. Yeah, I think that's kind of all we need to say there, really. So this is the context prior to the pandemic setting in. And then, of course, everything changed. So this figure shows the kind of changes throughout the pandemic. So in the orange bar, we have the kind of support that was commissioned for 2020, 2021. The blue bar is what was being provided during that initial lockdown in kind of March and April 2020. And the green bar is what we were finding at the time of survey. So that was around August and September 2020. So I'll just take you through this a little bit. So starting off with face-to-face advice, we can see there that every local authority surveyed had planned to commission and provide face-to-face support for 2020-21. But of course, that all kind of stopped as soon as lockdown came in, with just one local authority actually maintaining that. And by the time of our survey in August and September, we were seeing about 1 in 5 or just under local authorities offering face-to-face support. Telephone advice was very much like the most widely used form of remote support during lockdown. So we can see about 82% had planned to commission this for 2020-21. But even more than that, almost 100% were actually utilising this during lockdown, and still being maintained fairly high above commissioned levels by the time of the survey in August and September 2020. And text messaging, a similar kind of trend, very highly utilised, about 70% there commissioning it for 2020, 2021, and around 80% actually providing that during lockdown, and the same again at the time of survey. Video conferencing was the kind of biggest innovation we saw, and this one is where we really see quite a radical departure from what was actually commissioned. So just around 1 in 3 surveyed local authorities planning to provide it, but around kind of 2 in 3 or just under providing it during lockdown and at the time of survey. And a similar trend there for kind of email-based and web applications, but slightly less pronounced. So the kind of key point here being that, and one that's known and experienced by all of you, is just that COVID-19, really drastically reshaped across the board the delivery of behavioural support for smoking cessation. Unsurprisingly, and again known by you, this brought advantages and limitations. So I won't go through all of the kind of bubbles on the board here, but most survey respondents were positive about the novel services or the kind of expanded remote offers they were providing. And the reports on the kind of service user experience also did seem broadly positive, people citing that kind of flexibility, even reach in some places that they weren't seeing before. But the limitations were not insignificant. So at the same time as extended reach and flexibility, others were saying that there were particularly concerns that kind of socially marginalized groups were less engaged, that the quality of engagement could be a little bit worse, and things around not being able to see monitor people and kind of validate those quits were causing issues as well. But from what we saw on the survey, on balance, I think most local authorities were planning to maintain or retain some form of remote support as part of their offer, and that was kind of initial thoughts at the time of survey in September and August 2020. So this is just a quote that kind of from the survey respondents that I think kind of balances those pros and limitations quite well. I'll just read this out. So, as we are a small team, we only offer a couple of clinics which are not convenient for a lot of people due to geography and times. Virtual support allows more flexibility. It has also pushed us to develop other ways of providing pharmacotherapy, i.e. via electronic vouchers and direct supply. However, remote working can be difficult for team members to feel connected, and with more people coming through our service and less through primary care, there could be a greater disparity on our pharmacotherapy budget and less on CCG budget who fund pharmacotherapy through quit attempts and surgeries. Also, we are unable to see monitor service users, and it is unclear as to the true number of quitters. So moving on to kind of engagement with priority populations, this is something that we were maybe seeing increased focus on engaging these groups, or maybe it's part of a kind of continuing trend. It's something that we're going to be looking at in more detail in this year's survey. But from what we saw in 2020, the kind of pandemic seemed to cause a bit of a shift in focus there. So we saw about 3 in 5 local authorities making some form of special provision to support either vulnerable individuals or kind of priority populations as a result of COVID-19. So those population groups included homeless populations, people with mental health conditions, people who were immunocompromised, over 60s, people with respiratory diseases, and so on. So some of these groups we know to have high smoking prevalences, others, less clear. But what this often involved was giving a greater priority of access or making access easier through additional sessions and time for consultations, and also non-behavioural interventions. So, ensuring the supply of pharmacotherapy, even some kind of novel e-cigarette kit provision. And the large majority had planned to retain these changes at the time of survey. So about 78% said they would be maintaining this in some form. So as I say, we don't have a huge amount of detail on what this entailed, but it's something that we'll be looking at in the next year's survey. And then in terms of the change in demand for services, the graph here kind of presents a fairly simple picture, but what we saw was all local authorities basically seeing a fall in demand following that initial lockdown and then uneven recovery thereafter. So we saw about 42% here saying that demand was the same for them, around 20% saying demand was higher, and 38% saying demand was lower. As I say, there's not kind of a clear answer or pattern as to why some local authorities saw those changes that they did, but some things we were able to identify were local authorities and stop smoking services that were able to adapt quickly, implement new methods, and were not reliant on the NHS for referrals, were more likely to recover demand or even increase it following those kind of changes in the initial lockdown.
Robbie, you just need to speed up a little bit.
Oh yeah, no problem. So it's just to say though, that kind of mixed picture in the kind of demand we saw through the survey isn't exactly the end of it at all. So these two graphs are from the Smoking Toolkit study, which is done by UCL. And the top graph there, as you can see, shows the proportion of adult smokers that have tried to stop in the past year. And the bottom graph is the success rate for those stopping who tried. So we can see on the top graph there a real kind of pickup in motivation to quit effectively. So a greater proportion of adult smokers actually trying to quit, with about 36.1% in 2020 there. And on the bottom graph, a really kind of unprecedented levels of success among those who were trying to quit. And you can see this kind of mirrored in the stop smoking service returns. So this is, it should be April to September 2020 there. So this is half a year's data, but we can already see, an increase in success from those coming through the services as well. So just to kind of finish up here, I guess it's just to say that whilst demand for the services does seem to be mixed, there's a clear national trend of kind of increased motivation and success in quitting. And I think with regards to today's focus, the challenge this kind of wider context presents us with is understanding what contribution changes to the way we've delivered behavioural support might have made to these trends, versus to what extent these trends, and particularly those success rates, are the result of a kind of global health event. And none of that is to say that remote delivery hasn't been a part of that success. It's been an incredible year of innovation. We've seen some amazing practice and some really impressive results. It's just that as the dust settles, we'll need to determine specifically what about it was successful and disentangle that from the kind of wider context and other changes made locally, and consider, if and how outside of the context of a pandemic it will still have that success. So yeah, just a local interrogation that needs to happen, I think, everywhere, and those answers will differ for every local authority, I'm sure, as a result of different geographies and populations. So I will wrap up there and hand back over to Hazel so we can press onwards.
Thanks, Robbie. I hope that was useful for you. I think, the picture of what's been delivered over the last 12 months has been fascinating. And now we'll move on to our next presentation from NCSCT. So Louise Ross, I guess, will be familiar to many people as a stalwart of the smoking cessation scene in the UK for many years. And Sophia, a more recent arrival on our shores, an illustrious career on 2 continents, both in Canada and in Europe. Sophia, it looks like you're kicking off the presentation, so I'll hand over to you, and we'll speak later. Thanks.
Great, thank you, Hazel, and thanks for the opportunity to be part of today's session. Really interesting presentations, and Louise and I have been asked to talk a little bit about how we maintain the quality of behavioural support in light of the pandemic, but also coming through this, what we maintain in terms of innovation, and how do we interpret some of the research coming forward in what we do when we have in front of us a person interested in quitting smoking. So just a reminder, the National Smoking Cessation Centre, NCSCT, is committed. The whole scope of our work is to support high quality, evidence-based stop smoking support through English stop smoking services, but also through programs delivered through NHS. And we try to provide support documents, but also the training and certification that goes with that, and always keeping it up to date in an effort to do as best we can to support people interested in quitting smoking. Robbie's given a wonderful background of some of the challenges being faced in recent years, but in particular with COVID, the new service delivery models, the drop in NHS-related referrals, and how that has affected service delivery and demand for services. There has been, over the last few years, as we are all familiar with, a reduced number of smokers accessing services. Referrals from primary care being an interesting point where very brief advice should be leading to referrals, that those are dropping, or at least have dropped during the period of COVID for very, reasons that are very well known to all of us, the challenges that they've faced in clinical settings. And that we're seeing high-risk groups, complicated clients in stop smoking services, in particular in this last year. So what do we know about delivering behavioral support? This slide in its entirety we should all be familiar with, but I want to recap just as a reminder, and it speaks to Jamie's presentation earlier around behavioral support and what the evidence has told us. First of all, very clear, and as we knew before Jamie's review, the latest Cochrane review validates that behavioral support does work. It's an important part, combined with medication, of supporting individuals quitting. And we know for Stop Smoking Services, the work of others, in particular in the BOLD study, that we can triple the success of quitting using evidence-based stop smoking support. And what we know in addition is that that support is best received and most effective when it's delivered by a trained practitioner. That we know those that have a specialist advisor role, it's their main role of delivering stop smoking support, receive or are associated with better outcomes with respect to quit rates in supporting individuals. That of course it's the combination of medication and behavioral support that's key. And that we use evidence-based behavior change techniques, that we're not sitting in front of someone and coming up with our own mode of how we might support them, but rather we use very specific targeted behavior change techniques that have been shown to influence one's ability to quit, and that's the best use of our time. We also know compliance with treatment, whether it be the behavioral support or whether it be the evidence-based medications, and using them for the full duration. In our case, it's 6 contacts through English Stop Smoking Services, and with the medications for at least 10 to 12 weeks, if not longer if needed, is a really important part of keeping our support linked to high quit rates. I want to stop for a moment and again remind us of behavior change techniques and how that contributes to an effective service delivery. And you'll remember, perhaps in hearing this in the past, that work has been done in particular by Susan Michi and Robert West in 2011 to identify the behavior change techniques that are associated with quitting smoking. And I can tell you that at the NCSCT, we regularly look at Cochrane reviews, other evidence, and experience from the field to make sure that these continue to be what the evidence tells us is the best way to support smokers. And the latest review from Cochrane that Jamie spoke about really validates that these are some of the important, not some of the important, the important ways in which we will use our time. And BCT's behavior change techniques really are the things we do or say to smokers that will improve their chances of quitting smoking. 71 had originally been identified, 16 had really good evidence that they were associated directly with rates of quitting. And there was a clinical consensus meeting several years ago organized by NCSCT where we looked at the very top. If there were a few things you could do with your time with a smoker in a 20 to 40 minute session, these would be the 7 top. And just as a reminder, it is to use carbon monoxide testing to motivate quit attempts, to provide guidance and instruction on effective and appropriate use of stop smoking medications, to help individuals deal with cues for smoking and craving and withdrawal effectively, to adhere to the not a puff rule and make a commitment to that and to a non-smoker identity. And you'll know these all very well because they're part and parcel of service delivery that we provide. And we'll just go to the next slide, Robbie. Robbie, do you want to go to the next slide? There we go. Thank you, Robbie. And so again, these are all part and parcel, these behavior change techniques of the intervention being provided in the field, in the standard treatment program that NCSCT provides, and in all of the training interventions that we deliver. Next slide. And so just a little bit now about the issue of remote delivery and something that's become so pertinent during the time of COVID. Whether it's someone across the table from you in an office, by telephone, or by video, these are all in-person types of support, and all of them are amenable to the use of behavior change techniques. And there's good evidence that any type of in-person contact with respect to smoking cessation will be effective. There's less information about apps and technology-based interventions, although we see, and as Jamie spoke about earlier, that text-based is emerging as a promising intervention. And apps may, as more information is gathered, be an interesting alternative for delivering stop smoking services, in particular when other forms are not available. What I want to say, though, on this point of which mode we use to deliver services, not only during COVID where it was forced, but after COVID, really the issue of one size does not fit all. And what we may be seeing in the field, and what my experience working in Canada for many years, where there were not stop smoking services in communities across in Canada, across communities, is we used a lot of telephone, video, and other forms of delivery, but always using in person. There was a real person on the other end. We also had face-to-face, and there were particular clients that chose each delivery based on what they knew to be their needs, what would keep them engaged, which would provide a more tailored experience to them. We've done survey work on this as well, and I just want to summarize by saying the truth is that one size will not fit all. So if you are a service or a manager commissioning services and are thinking about choosing one of these modalities going forward, that certainly is an option, and the consequences of that is that we may, if you will, not attract particular groups of smokers to our services by limiting choice and mode of delivery. And in fact, if we look in the future to offering telephone only or telephone combined with face-to-face and the option of video and other forms of delivery as they become available, we may attract new smokers to services. It's a really important part of expanding reach is to think about modality as a way in which we can extend services to groups that might not otherwise have been part of clients that we've seen. Next slide. The next slide is just showing to you the BCTs, and there are some considerations when we look at mode of delivery and what we can provide in terms of BCTs. And for the most part, anything that is in-person support can certainly provide much of what can be delivered in a face-to-face visit, and that includes building rapport and the importance of that, talking about stop smoking medications, the not a puff rule, etc. What you have already learned, and it's very obvious, is CO monitoring, which is a motivational tool, can only be done face-to-face. Explaining or demonstrating medications and watching the client can certainly be done by video, not very well by phone, and it's certainly much easier to do face-to-face. So some considerations around particular client groups that may need more, if you will, hands-on contact that should be in the back of our mind. But for the most part, all others can be done by phone. And taking a little extra time to ensure that if we're doing video, that we pull medications out, we have the client try them in front of us, we have them ourselves available during the video, and can really spend a few extra moments, given that it's not the ideal if they're not in front of you. So next slide. So when we think about technology-supported quitting, whether it be text messaging, person-based, online, virtual apps, I want to throw out there the phrase high-tech, high-touch. That anything that is remote delivery, that is being delivered through IT or IT-enabled, really attempts to keep that face-to-face contact, is focused on behavior change techniques. And until the evidence is there that they can be standalone interventions, our view at the moment is that they are second line and an alternative to in-person or face-to-face. So for example, whether it be app or text message, if someone can't come into a service, that's a great second option. If they can, however, they probably will be best served, the evidence tells us, face-to-face telephone or video. And to throw out there the adjunct to in-person counseling, that these modes of delivery, text-based and apps, can be a complement to providing support in between sessions, and they should be used that way for the time being. I just want to offer up on the next slide as well a nice example, one drawn from my experience in Canada, of how telephone apps and text messages are being used to extend services to clients who are seen at least once in person, that will have their medications prescribed, will have a tailored in-person assessment done, and then have the option to choose to continue face-to-face or use one of the other forms of communication to receive stop smoking support. And this is delivered over 6 months, and it's delivered over 6 months with many, many contacts in a cost-effective manner by using some of the technology to offer that. And certainly apps that can allow individuals to start off there or be recruited through that mode, but connect them when they need support to a real live person it can be quite effective and a nice place for us to be looking. So I'll just wrap up then, next slide, but reminding us again that while we've seen a drop in the reach of services and clients choosing to use stop smoking support through stop smoking services, we've seen us maintain, and Robbie showed those numbers, quit rates that are quite high. And so staying focused on what can be used to achieve that efficacy, maintaining quit rates is really important. At the same time, this innovation that we through COVID is teaching us a lot about who we can reach, which clients are best served through different modalities, and how we can keep clients engaged. Not everyone stays engaged with things, video or telephone, and may need some in-person support, and others will be more engaged through that type of contact, making it more feasible. And just looking at the next slide. So reach, engage, and help people quit is really our focus. On this slide, I don't want to spend time on it, but these are the different types of things that we can do in planning services that can expand reach, reaching out on very brief advice and ensuring that our primary care colleagues and others are promoting services and referring clients, offering flexible options that can meet more people's needs, outreach, and we know the NHS is doing a big piece of work in secondary care, and there'll be referrals there. We heard about incentives and how that can attract individuals and help them keep smoking. And we also heard today about harm reduction and reduce to quit approaches and how that can attract another group of clients that might otherwise not be ready to quit smoking. Engaging services, again, incentives and keeping people engaged in flexible service delivery models, building rapport and having them connect to the individuals providing support to ensure they continue to come through. And of course, quitting, we've talked a lot about already. So I think this is the final slide, and it highlights something that was brought up in the ASH survey is during COVID, the reduction in referrals from NHS, whether it be pharmacy or primary care. And, you know, an estimated 3 to 5% of GPs have been trained in very brief advice. That is a very small proportion of the general practitioner community. And we know that receiving training in very brief advice is directly associated with increasing referrals to stop smoking services. So one message to take away is to make sure our GP colleagues or pharmacy colleagues are receiving the training to allow them to do their job better and to increase referrals to services. I think it's a simple target, but one that is a message we want to make sure we get out there. And I'm going to turn it over to Louise. Lou, were you there?
I'm there, yes. Hello, thank you, Sophia. So I'm going to carry on talking about applying the theory to practice. And I want to apologise to any stop smoking veterans out there who may think we know this sort of stuff. But this is particularly directed to new advisors. I know a number of people who have joined stop smoking services during the pandemic. And you know, they may have only experienced delivering remote service treatment. Also, people who are triaging on the phone. There's something very, very subtle, I think, about the way you talk to people who want to come into the service, and it's important to kind of listen out to that kind of hesitation. If you say, well, you know, we deliver our service by phone, you know, if they don't seem happy with that, you know, the option of face-to-face should be reverted to straight away. And the other audience that's particularly important for this is commissioners who may not have sat in that seat, you know, dealing with smokers face to face, but who need to know that there, exactly as Sophia said, you know, it's not one size fits all. There are different ways of actually dealing with this. So who might do well with phone or Zoom or apps, and who might do less well? The people who are going to really benefit from remote delivery, I've listed some of them here. I'm sure you'll think of others yourselves. Busy parents with kids who, you know, as we know, often you know, DNA from their appointments because, you know, one of their kids is off school, or, you know, they just can't get, you know, toddler in the pushchair and you know, the older one's kind of sorted out to get to an appointment. So remote delivery, really, really important for that particular group, for busy parents. Shift workers, And very often in routine and manual jobs, people do double shifts, especially like in the food industry, for instance, a double shift that's suddenly kind of put on you, or you've got the opportunity to do overtime. You're going to choose to do the shift rather than say, now I've got an appointment at the stop smoking service. So if it's something that can be fitted in by phone, then that's so much easier, or on an app as well. And this applies to NHS workers too, who often have their shifts changed at the last minute, or have to stay on because there's not enough cover. So those sort of people really benefit from the flexibility that remote delivery offers. People with poor mental health, who we know can find it very difficult to kind of get moving in the morning, rather than have them DNA from a face-to-face appointment, having a remote appointment can fit in with their lives and the limitations that their condition might put on them so much easier. And that applies to all slow risers. When I was running a stop smoking service, we often found that the 9 to 10 appointments were the most DNA. People take a bit of time to kind of get going. So again, if they can stay in bed and just pick up the phone and talk to you, so much easier. Carers who very often smoke as a way of kind of sorting out their day, having a little break for themselves, and they neglect their own health because they prioritise the health of the care of the person that they're looking after. So they may not attend an appointment if the person that they're caring for needs extra support. They'd be very good for remote. And people with mobility issues. I mean, at the moment, if you need to get a bus into town and the seats in the bus are restricted because of COVID, and the bus sails on by, they're not going to get into town. So that was just a little kind of snapshot of the sort of people who might do better with remote support. Next slide, please.
Louise, sorry, just to say we're running slightly behind time.
I know. I'm talking as fast as I can, Hazel, and I'll cut bits out. People who do better face-to-face, people who connect visually, obviously, people with hearing loss. We often hear now that people with hearing loss have really struggled during COVID to to have their services in whatever form by phone, because it's much harder. Couples coming together, 2 for 1 is good. And people who need to see a demonstration, for instance, of using a vape. It's so much easier to actually show them when you've got them in front of them. Next slide, please. And for your own benefit, delivering remote support, it's been described as being a bit like a hamster in a wheel or on a conveyor belt, because you can see more people when you're not having to travel to appointments in different clinics. It's important to look after your own well-being and refresh yourself as much as you can in between appointments, so that you still convey the passion, and that you can paint a picture. So if you can't do carbon monoxide monitoring, you can paint a picture of what that red light or the green light looks like on the monitor. Paint a picture if you can't actually do it in real life. Keep your energy high and refresh yourself. Do a swift bit of exercise in between your appointments, so that you do convey by phone to the person you're speaking to that you're really invested in their quit. And read the NCSCT guide to remote working. Next slide, I think, is probably the last one, and that's about resources. Check out the NCSCT website, especially look at the new cannabis guidance if you haven't already. I said I'd do a plug for that. That's me. Thank you.
Admirable speed there, Louise. Well done.
Thank you.
Thank you so much. And I will, hopefully we will have time to get to questions. So do keep posting your questions in the box there. So now we're going to move on to our case studies, and we start in Essex with Sarah Tinker and John Gear, and they're going to talk about what they have been delivering over the last 12 months. So over to you, Sarah and John.
Oh, thank you very much, Hazel. Let me just see if I can share my slides. As always, the waiting with bated breath moment. Hopefully you can see that. Right, unless I hear otherwise, I shall assume you can see. Yes, thank you. It's great to be here. And yes, I'm Sarah Tinker. I lead on tobacco at the moment on Essex County Council. So a little bit of background about Essex. We're one of the biggest counties in the country with a population of approximately 1.8 million. We're a mix of rural and increasingly populated areas and have pockets of affluence and deprivation. So Jaywick Sands on Essex's east coast is the most deprived locality in the country. We have 5 CCGs and 3 ICSs, which means we have a really wide spanning and intricate health structure. And our prevalence figures for smoking are around 155,000 people in Essex, and thankfully have been on a steady decline over the last few years. We commission an integrated lifestyle service, which includes a dedicated stop smoking service delivered by Provide. Up until the pandemic, Provide were delivering up to 46 face-to-face clinics weekly across the county, as well as commissioning GPs and pharmacies to deliver quits. That all changed when COVID hit. So the outbreak obviously drastically changed our delivery capacity. Due to the large numbers of vulnerable and shielding residents in Essex, the lifestyle service transformed into the Essex Wellbeing Service, serving vulnerable and shielding residents. Most staff were called on to support the effort, and some clinically trained staff were also called in to support secondary care response. So we needed to onboard thousands of volunteers to support shielding, testing, and now vaccinations across Essex. Whilst the capacity of the smoking service became smaller, the single point of access was expanded and still able to pick up referrals, which was good. And I'll now hand you over to John Gear, who's the Health Improvement Specialist from Provide, and he's going to talk to you about the actual service delivery itself.
Thank you, Sarah, and good morning all. In response to the pandemic, we postponed our core routine face-to-face clinics in favour for remote telephone support services. We were able to source a pharmacy to administer our NRT requests electronically, post first class recorded, and this allowed us to connect and deliver to our service users without any need for face-to-face contact from the service user's point of view, but also for our staff, negating any need to attend the office. We do incidentally offer text support and video conferencing, but neither have proved popular throughout the past 12 months in our service at least. Now, I will touch on vapes. We work with selected vape stores that are first vetted by trading standards and then trained by us to deliver the effective behavioural support alongside the service user purchasing their own device. The programme did continue in face-to-face formats where possible. We have electronic equivalents and we have telephone support also available from the stores during those periods where face-to-face is not possible. Sarah, next slide if you would. Thank you. Now, understandably, pressures in primary and secondary care, our traditional sources for referrals were hindered. Self-referrals, incidentally, have been very consistent when you compare to the previous year. Pharmacy, we subcontract the local scheme to our LPC. Now, they do an amazing job on motivating the sites to seek out smokers. They, over the year, have run various campaigns to increase engagement levels, incentives for service users and for staff, and they really have driven forward the footfall. Now, we have had feedback across the year from service users that, thankfully, COVID motivated them to engage with our services. Now, one would hope, and the data is still emerging on this point, to see whether they are people that would not have ordinarily engaged with us. Now, in terms of performance, of course, I will say our collective team have performed brilliantly in the past 12 months, but I think there is certainly something to note in the fact that our success and conversion has actually been very strong, even compared with the changing in delivery methods. Savings have been made with our higher outcome rates and the removal of face-to-face clinics. but of course we've got to offset that against the cost of posting the medication via our pharmacy. Unforeseen benefits during the past period really has been COVID bringing people to our door who may have not otherwise engaged. We have a great deal of feedback to support that. Again, it's too late really to comment on the data. And incidentally, this period, the past 12 months, has really accelerated our service integration with community partners, allowing us to expand our service offer. Sarah, next slide if you would, please. I'll carry on for time's sake. So future delivery. It's likely remote clinics will remain as our substantive support offer, possibly some satellite clinics for the priority groups. The casualty, of course, as already been mentioned, is the carbon monoxide monitoring. Now, we will be continuing to work with the services to re-engage with them, but I think the hangover effect of COVID on primary care services will be lengthy. And whilst it was mentioned earlier about brief advice training for GPs, I think we need to be mindful of our expectations from surgeries in the coming months, possibly years. Evidence is telling us that vape stores, or vapes rather, are smokers' preferred cessation choice, and we're getting a lot of feedback to back that. Now, with lockdown easing, we'll be refocusing our efforts on signing up further stores to deliver our programme in that regard. The LTP, Funded Tobacco Dependence Treatment Objective, gives us a great opportunity with hospitals, so we'll be focusing resources to support that, push for further partnership clinic delivery with the voluntary sector, and also our workplace health programme is a really strong contender for opportunities in the future. Now, in closing, before I hand back to Sarah, I think it's fair to say that whilst smoking rates are in decline, and COVID has brought new opportunities and challenges, the low-hanging fruit has largely gone. And so as smoking cessation services, we do need to find new innovative ways of engaging with our smokers. Thank you, and back to Sarah.
Thanks, John. Sorry if you couldn't see the slide change there. Slide changed on my screen. Yes, absolutely. As John says, the future should definitely not be dictated by how service delivery has looked in the past. We need to be thinking outside of the box. We'll definitely look to build on positive feedback that we've received from the people using our services in order to create a hybrid model that will meet people where they are. We want to lessen our reliance on primary care, who are extremely busy, and look at how we could utilise the huge community volunteer pool that we've attained during the pandemic, who can help to reach our target groups. We also want to continue the integrated partnership delivery that has grown out of the COVID working, particularly with social care providers, and expand on it to further widen our reach. And I will just finish on this. Obviously, it's been an incredibly difficult time for our services, and we're so grateful for everything that they have done to continue to support people. Here is Jenny, who is a quitter from Essex, and she has had great success during the pandemic. Let's see if I can move this back. Oh no, you're right. I'll let you read that when you get the slides sent round. But yeah, so just to end there. Thank you.
Brilliant. Thanks so much, Sarah and John. Really interesting to hear what you've been doing over the last 12 months and how that's going to influence things going forward. We're going to move on now to Maggie quickly so we can have some questions at the end. Maggie is a service manager in Sheffield, and as well as doing that during the pandemic, was also helping us out with some of our National Quit for COVID work, so all-round hero. So I'll hand over to you, Maggie, to talk about what's happening.
Hazel.
I know. Where does the time go?
I know.
I'll hand over to you to talk about Sheffield.
Thank you. Hi, morning everyone. I don't have a presentation, so I'm just going to talk you through some points of our services during the pandemic. So before I start, I actually manage the Yorkshire Smokefree service, but I belong to a team of stop smoking services within Yorkshire Smokefree, and those services are Sheffield, Barnsley, Doncaster, Calderdale and Wakefield. And as a Yorkshire Smokefree service, we've all worked together on the points that I'm just going to address this morning. So I would like to acknowledge the other services as well, because we've worked quite well together. So like many other services, we've had to quickly switch our style of delivery following lockdown measures, and most of the services that I'm referring to within Yorkshire Smokefree did these before we were actually asked to do them. So with respect to Sheffield, we run all our clinics within GP practices, and we also have a unit in our local market. So as you can imagine, the market was closed straight away, so we had to quickly move those to telephone support. And then the GPs didn't want us in their premises, obviously, because they didn't want the footfall of people going through the practices because of lockdown. So Yorkshire Smokefree also already has a very successful telephonic hub that supports all of our 5 services, alongside the face-to-face delivery of our other services. So we'd already got that in place, but obviously that couldn't accommodate the whole of the services going to telephone support. So very quickly we came out of the face-to-face environment and then hooked up with telephone support, and we were really lucky that all of our team of advisors already had agile equipment, so we could quickly get them into the home and get them up and running. They've got VPNs, telephones, laptops. So we do know that there have been some other services that they've had a delay in that because they've had to order equipment. So we were very lucky that we were ahead of the curve, really, with regards to that. Prior to the pandemic, Yorkshire Smokefree were migrating to an electronic voucher system from paper, and we intended that this would go live from April, but we quickly had to, well, I think it might have been May, beg your pardon, yeah, I think it was May. So in order to be able to reduce the risk of people not getting medication, we quickly were able to get this electronic voucher system implemented literally overnight. And we did have some hiccups along the way, but we worked through them as a Yorkshire Smokefree team, and we quickly got things up and running with pharmacies, etc. So that obviously enabled all the service users that were switching to telephone support to have instant access to medication via a text message being sent to the phone, and then they'd take that code, or they'd take the phone and show the pharmacy the code, and then they would dispense that medication instantly. So we found that a massive help during the I can't think of the word, but there's been no disruption in service delivery. We've been able to see someone face to face on Monday and ring them again the following week, explaining why we're doing this. So although the e-voucher wasn't developed, obviously we wouldn't have known about COVID. COVID enabled us to just get on with it rather than trying to implement it in a phased approach. So we just literally went regional with it, with across the Yorkshire Smokefree services. And now that we've moved to telephone support, as I've just said, it's enabled us to continue with that service delivery and offering clients medication, and that's obviously Champix, Cyban, where applicable, and nicotine replacement. So what did we do then? So as I've just explained, we moved to telephone support very quickly, and we were quite concerned about the impact that would have, because we've always been able to offer a very varied approach to quitters. We can offer face-to-face, telephone, we send text messages already. We had a website that was would enable people to go through the programme without getting in touch with you know, support services, etc. So they could do that on their own. But we had to be demonstrating, really, I think, during this process, that we were doing something more innovative than just telephone support, because Yorkshire Smokefree was already built on the foundation of a telephonic hub. We felt that we had to be doing something more, you know, virtual as such. I know that other services have already been doing it, and I've had chats with Louise about it previously, and Robbie's presentation clearly demonstrates that that is a really successful way to engage with all sorts of different smokers that you know, like we've just heard, that they may not have wanted to come into services for whatever reason. So we quickly had discussions around offering video consultations, and we've got a steering group set up across the services. and we are now starting to implement these. We've had lots of funny, funny stories. One particular clinic I had to run because someone was off sick, and I phoned her up and she was in Tesco, and I said, oh, well, I'm sorry, I'll call you later. She said, oh, no, it's fine. So we did a full 20-minute consultation while she was shopping in Tesco, which I thought was just amazing. And I wondered, actually, after I'd had a chat with her, was the pharmacy in Tesco, and did she actually get her medication while she was shopping? So, we've had lots of real good stories around the telephone support. Also, what we do is we carry out an holistic assessment with all clients when they come into the service, and this has proved really useful. It's always useful, but during pandemic, obviously, people have got a lot more worries and concerns. They may, be having higher incidences, mental health, relapses, etc. So we've been able to identify anyone that is struggling in other areas and being able to signpost and refer them on to other specialist services. So, and again, because of the pandemic, this has enabled us to get familiar with approaching questions around other issues in their life and things that might be impacting on people quitting smoking. So, again, that's something positive that's come out, because I'm sure for all the service managers out there, oh, you can't give us something else to complete, we've got something else to fill in. But again, because we've had more intensive consultations with clients, then obviously these issues have been coming up. Right, so going back to telephone, to virtual, how did we promote them? Well, the problem is that people go, no, I don't want to do face-to-face. So, we would start by asking the client, well, did you engage with your family during lockdown, and did you have a Saturday night quiz and stuff like this? And then they will have said, oh, yeah, we did. And so then we'd encourage them to use that as a way to get people into thinking about video calls, and that if they came into services, you'd be sat face to face with someone. So some services are ahead of Sheffield, like Calderdale are already and Barnsley are running groups, and we ask the clients to download Microsoft Teams, and we get their email address on registration, and then we send them the email and the invite onto Teams. Microsoft Teams also enables us to have breakout rooms, so when we get new clients that come on board, we can take them privately off into an area where we can do the registration, and then we can ask them to come into the group. Calderdale was very experienced at running groups, so that they're now getting that up and running. So it'll be interesting, if we get the chance to feed that back to see how that's panned out. We're also looking, and we've purchased some Bluetooth single-use monitors that we are going to post out to clients on the virtual consultation, so that we can demonstrate carbon monoxide. I mean, we do talk about it anyway, but obviously to be able to do the test while they're with us virtually and show us the result on their mobile phone, then we think this is also a really good way to encourage people to take up virtual support. So
Maggie, I just encourage you to make the last few points.
All right. Oh, I'm such a rattler, aren't I? Anyway, so just quickly, we've developed our website, so now we have a client area, and they can log in and they have access to all our resources electronically, etc. Lots of other things, but I don't have time. And I think moving ahead and looking at recovery plans for services, we're thinking now of offering blended approaches to quitting, which will encompass all of the things that I've spoke about. Thank you.
Thanks, Maggie. I think it's really interesting, the sort of blended stuff is really coming out of this webinar as an approach, and the group stuff I think is very interesting too.
Yeah,
so
it'll be interesting to see how that pans out. Yeah, thank you, Hazel.
No problem. Thanks, Maggie. And we'll now hand over to Julie Harrington, who's going to finish our case study session before we move on to do a few questions. Julie is from Bath and North East Somerset Council. Julie, over to you.
Hi everybody, and welcome to Somerset. Hi, I'm Julie Harrington and I'm the lead for smoking cessation. Actually, I'm employed by Virgin Care and we're commissioned by Bath and North East Somerset Council and Community Health and Care Services. So last March, obviously, a pandemic was a bit of a shock to us, and I think we all went home thinking that we're going to leave our face-to-face services for a little while, and 12 weeks time we'll all be back again and everything will be lovely and we'll forget this ever happened. Of course, we all realised quite rapidly that that wasn't going to be the case, so we suspended our face-to-face offer very quickly, and we reverted, as everybody, to texting, telephone and emailing in some occasions. We found that actually telephoning worked very well. What we do is we triage all of our referrals. So all of our referrals are calls by either a stop smoking advisor or one of our trained admin staff, who then give some very brief advice and then book a client into a telephone clinic. We're very lucky that we've already had in place an NRT voucher scheme, which worked very well. Previously, we would have handed the voucher to the client and they would take it to a pharmacy, but we then made sure that we were using a secure email service to email our pharmacies. Initially, we had a little problem because the pharmacies were so overwhelmed. It meant that people had to maybe wait a few days for their NRT, but generally here we're very lucky that most people can see a stop smoking advisor and on the same day or the day after can receive their NRT. Our Shampic request works in a very similar manner, where we use our internal system with the GP practices to request Shampics, and again, Shampics can be prescribed very quickly and very easily. We did find that COVID broke down a lot of barriers for us, and that previously we would have had to jump through hoops to get quite a lot of things done, but we found that very rapidly that diminished, and it made life an awful lot easier for us. In particular, we decided to offer a free e-cigarette vape kit, and we purchased initially 50 vape kits, and there's a little bit of information there. Thank you, Robbie, for the information on our free e-cigarette pilot project. Millie produced this wonderful infographic, which I'm happy to share with any of you. We purchased the e-cigarette kits from Totally Wicked, and we send clients who would like it an e-cigarette starter kit, and initially we bought enough oil for them, or the liquid, to use for a whole 12-week quit, but we've actually realised that most people don't want 12 weeks worth of oil. They're happy to then provide their own, so we've got stock of that at the moment. So our e-cigarette pilot scheme has been very popular and is now actually embedded into our service and our offer. We managed to receive some funding from Curo, who are our social housing provider, and for 50 starter kits for vaping, and we prioritised people who were shielding or were unable to leave their property to have a cigarette. So we trained Curo to dispense e-cigarette kits and refer to us. So they dispensed starter kits, and it was to encourage people that couldn't actually leave their property to smoke to harm reduce in some way. And we have seen that it's been very popular with Curo, and we've been very grateful to our social housing provider for what they've been able to do to help us there. We also managed to provide our homeless shelter in Bath with some e-cigarette kits, and these were for the residents that were taken off the streets. Everybody in Bath and North East Somerset were offered housing of some form, and also all of our homeless community were offered a free e-cigarette if they would like it. We had a massive win there with the manager of the shelter actually started vaping last April, and that was a great win for us because many of the people in the shelter saw him as a good role model, and which really helped us. So our homeless shelter really benefited from our e-cigarette pilot. We also purchased 50 licenses for a Smokefree app. We have some data for that. We've at the moment to date, I think we've actually handed out someone looking at my colleague Joe who sat next to me, about 20 licenses. 11 of those licenses have been used, resulting in about 524 sessions on the app, and most of those sessions are out of hours. So we are seeing that if people are offered the use of an app, they do use it, and they use it at a time when they cannot get access to a stop smoking advisor. We have 5 reported 4-week quits from that, so the data is very small, but we are continuing to monitor the use of the app and to give it to those people who may find it useful. We use Totally Wicked for our e-cigarette pilot. We've used them in the past, and I know probably other services will say that they've had a similar experience with them. What we have seen is more referrals from GP practices, lots more referrals from primary care, and still a trickle of referrals from secondary care, but not as many as we would hope, same as all of you, I'm sure. We've seen a much better retention rate, so people tend to stay with us for longer. We don't have as many DNAs, and we don't waste a lot of time sitting in clinic. I don't know, previously we ran quite a lot of drop-ins, so we would wait and you may see 10 people a drop-in, or you may see nobody in a drop-in. What we're seeing is we're getting a much better retention rate and less DNAs, and I think moving on, possibly we will consider changing that face-to-face offer, and we will resume a face-to-face offer because some people like that interaction, but I think it will be an appointment-only system. We won't be doing any more, sat in drafty village halls waiting for somebody to turn up. We've saved money on cost of venues, and it saved us an awful lot of time. We did have some worries about IT poverty, people not being able to engage with us, but actually we've not really seen that happen. Most people have got access to a telephone, if nothing else. So although some people may not have access to a smartphone, most people have access to a telephone, even if it be a landline. So we have not actually seen a decline in people wanting to access us because of IT poverty. We've also been able to offer very brief advice training to an awful lot of our partners. When the pandemic first came upon us, we formed, same as Essex, like a community wellbeing hub, which joined together lots of partners, Citizens Advice, Mind, DHI, who our drugs and alcohol service, joined lots of other services together, and it's been amazing that we've been able to deliver very brief advice training to all of those, which means that all of our partners that we now work with are trained to deliver very brief advice and to give advice on vaping, to dispel some of those myths around vaping. That's been a massive benefit to us. And I think today, I did a quick tally up yesterday, that we've trained about 400 people in delivering very brief advice, which has been a great win for us. As we all know, it hasn't got to be us with the message. We've got a mental health. We have a wellbeing house in Bath. The wellbeing house takes people that are in crisis or who have left mental health services, and we've trained all the staff at the wellbeing house in very brief advice, and again we've offered them the free e-cigarettes, and we've also provided them with some NRT, which can be used short term until someone can get access to a stop smoking advisor. Joe, my colleague who is sat here beside me, likes to say that we offer a pick and mix service. So she'll laugh at that, and it is a pick and mix. And I think what has been important, I was really interested to hear what Jamie was saying about a tailored quit, because that's what we feel we offer. Some people would like face-to-face, some people want to use an app, some people want to speak to you on a telephone, some people want a text every 2 weeks. And that has led us to think ahead of what we're going to offer in the future. And we're just in the process of planning our next campaign, which is called Build Your Quit. Build Your Quit is based, and I apologise to those colleagues from lifestyle services who offer weight management, or like a burger menu, although it's not going to be based on a burger menu. That you go into Five Guys and you choose your burger, you choose your filling, you choose your sides. You adapt your burger to suit you, and your Build Your Quit campaign is going to be about a tailored quit to provide support that you need. Not everybody wants all of our pick and mix, but some people like to dip in and out of it. So moving forward, we're planning our pick and mix campaign, Build Your Quit, and we're doing some work with our ethnic communities, which we must admit in the past we've not done a lot of. So that's a big, quick whiz, because I know we're short of time, of what we've been delivering here. I think for us, COVID has been a very positive experience for us in many ways.
It sounds like it, Julie. I'm totally taken by the pick and mix thing and the build your own quit. That sounds absolutely fascinating.
Sweetie love, our pick and mix campaign.
I think it really picks up on some of the themes coming out of the discussion. I'm just going to ask the speakers to join us. I don't think we do have time to go into many questions, but it's been such a fascinating set of presentations that I don't think that that's necessarily a bad thing. I'm just going to ask people for their final reflections before we go. So just to give you some warning that I'm coming to you to kind of ask for your very quick kind of take homes for people. But I just wanted to reflect on what mine were. I think this notion of how we take the idea of a tailored quit and these blended approaches and try and take that forward is really interesting, and there's lots to learn from there. You know, thinking about the different populations and how we might reach people in different ways, the opportunity of new partnerships that are emerging from the pandemic, also really interesting. And I shouldn't say any more, I should let people say other things. But you know, a really fascinating discussion today, and I would urge people, we send around an evaluation form after this. Please do add your thoughts about how you would like us to continue this conversation in future webinars, because I think this is the start of a conversation, not an end. So Sophia, I might come to you first, or no, I should come to Jamie first. Jamie, for your kind of take home for people from this discussion today.
Yeah, I suppose for me, it's that we really do have very compelling evidence that behavioural support increases quit rates, even when medication is being given. I suppose we weren't surprised to see that really clear evidence for behavioural counselling, but possibly slightly more surprised to see that really strong evidence for financial incentives delivered in kind of the general population of people who smoke. I saw there was a question about amounts of financial incentives, so I'm hoping I'll have an opportunity to provide a written response to that, because there's much I could say.
We have a lot of specific questions about your presentation, actually, Jamie, so we will answer those in writing, but we don't have time now. Sophia.
Okay.
I think for me, it's just to see all of the innovation that's occurring and that this will continue post-COVID with all of the lessons learned. I love the individualized quit. I think it takes everything we've seen from the evidence that Jamie presented to the experience during COVID to what we know works in other areas of our life is to make this a personal experience. It'll keep us more engaged and it'll be more effective in delivering support.
Louise.
I'd just like to say how impressed I always am about the resilience and the resourcefulness of stop smoking practitioners, you know, who don't need to be told how to pull more people into the service. They just go and do it.
Yeah, absolutely. The creativity has been so impressive. Robbie, I missed you out, so I'll come to you.
Oh, no, not at all. I guess less of a takeaway and more of a request for people to, as Hazel said, both add your thoughts to that evaluation form, but also just get in touch with us and let us know about what kind of new things you're trying over the next few months or what successes you've seen. We'd really, really love to hear it. So please do get in touch.
Sarah.
Yeah, I think for me it's something around, we talk about there being sort of, we've got all the low-hanging fruit, but I think people do really want to quit, and I think it's just keeping going with what we're doing, and these hybrid models and these pick and mix is just a brilliant way to do that, just to keep that reach going as far and wide as we can.
John, do you have anything to add to Sarah's?
Yes, only say very interesting stuff from everybody. Thanks for that. I think personally, self-service is something that we should also be considering for the future. I like the idea that Maggie mentioned, websites where people can get support without the need for advisor. Now, I know, of course, the data, the evidence, the support is the key, but there is a demographic that I think would be interested in going that route if perhaps they are the easy service user that don't necessarily find themselves wanting support. So I think that's an interesting avenue to explore. I also liked Julie's mention of purchasing e-cig starter packs. I'm a big fan of that. I think there's great potential to engage with that audience. Of course, it's controversial, the evidence and convincing risk management to be on board with it, but I think that's a great engagement tool.
And more services kind of doing that, I think, giving people greater confidence that it can be done effectively. Maggie and then Julie, and we will then wrap up.
I just think I agree with what everyone said. We've just got to keep evolving and growing in how we offer how we offer support and delivery, and obviously we can't let blended approaches. We can't allow one to favour the other. We've got to make sure that we encompass all of them, and I think working together and sharing information and best practice is the best way forward.
Absolutely. Hopefully we can help facilitate some of that. And Julie, we leave you with the final word.
Well, I think that, it's amazing what we can offer. We've all come a massive long way in the last year. I think, embedding the standard treatment programme in everything that we offer in some way or another, I think is still vitally important. The support from the NCSCT, I think we need to keep that at our core, remember that. And also, I'm fascinated by the financial incentives. I think that's what we really could explore about financial incentives. And I think that would be a really positive move going forward. I think it would get people in the door. And anything that can, more bums on seats is good for all of us, isn't it?
Well, I also think the financial incentive stuff is interesting, and thinking about things like e-cigarette starter kits as part of that sort of incentive stuff is an interesting thing. So revisiting all of that in the future, watch this space. Thank you so much to all the speakers for sharing your expertise. It's been a really fascinating session. We will circulate the slides, we will circulate the recording, we will come back to you on the questions that we've not been able to answer. Thank you everyone, and have a lovely rest of your day.
Thank you everybody.
Thank you, Hazel. Bye.
Bye.